Hey, podcast listeners, Fawaz Al-Mufti here from Westchester Medical Center, New York Medical College, and I'm your host on the Neurocritical Care Society podcast. Traumatic brain injury is the single most important cause of death following traumatic injury and represents a major cause of long-term disability among survivors. Within secondary brain injuries, systemic hypotension plays a major role as its depth and duration have been associated with increased mortality and worse functional outcome, which is believed to be due to the failure to achieve the optimal cerebral perfusion pressure. Current guidelines suggest the use of intravenous vasopressors to support blood pressure following TBI. However, these guidelines offer little guidance regarding the optimal choice of early vasopressor to support blood pressure, and this has resulted in a variation in clinical practice. Personally, my go-to vasopressor of choice is norepinephrine, but I will admit I have very little data supporting that, other than the fact that I'm able to rationalize that this makes the most sense to optimize cerebral perfusion pressure in the setting of impaired cerebrovascular autoregulation. One group decided to conduct a retrospective cohort study of patients enrolled in the NINDS-funded multi-center transforming research and clinical knowledge in traumatic brain injury, the TRACK-TBI study, looking at the initial vasopressor choice for the support of blood pressure following TBI and its association with clinical and functional outcomes after injury. Today you will hear from Dr. Cassie Cronfield as she discusses with Dr. Vijay Krishnamurthy on behalf of his co-authors the recent article entitled Association of Vasopressor Choice with Clinical and Functional Outcomes Following a Moderate to Severe Traumatic Brain Injury, a TRACK TBI study that was published in the Neurocritical Care Journal. I hope you enjoy this episode.
Welcome to the Neurocritical Care Society podcast. I am Cassie Cronfeld, and I am a neurointensivist at Harbor UCLA Medical Center. Today, we will be discussing a recent publication titled Association of Vasopressor Choice with Clinical and Functional Outcomes Following Moderate to Severe Traumatic Brain Injury. This paper was a collaboration by the TRACK TBI study of 18 Level 1 trauma centers. We are excited to welcome co-author Dr. Vijay Krishnamurthy, Associate Professor of Anesthesiology and Population Health Sciences and Interim Division Chief of Critical Care Medicine at Duke University to the podcast. Thank you for joining us, Dr. Krishna.
Thank you very much, Dr. Cronfeld. I really appreciate the opportunity to speak with you today about the study.
Thanks so much. First, can you introduce our listeners to what the TRACK TBI study is?
Oh, sure. The TRACK TBI study is a really wonderful cohort study that was conducted across 18 centers in the United States, including actually all stages of TBI, so mild, moderate, and severe. The beauty of the study is that it was one of the few in this country large coordinated efforts to actually measure TBI care in the hospital and up to a year post-discharge. And in patients that were hospitalized, also collecting detailed data on laboratory and imaging parameters, as well as a biorepository of biospecimen samples available for additional studies. So it served for myself a wonderful database to conduct. My specific interest is around critical care, but a wonderful database to conduct studies examining the critical care of patients with TBI because of its robust outcomes information. There's just very few data sets that have done standardized exams out to 1 year after injury.
So true. So often it's difficult to get the long-term outcomes on these patients. And of course, it was relevant to this study in particular. Getting to your publication, the current guidelines for management of TBI patients, of course, do include blood pressure targets. Can you describe how this led to the motivation for this project and why it is so important to address this question?
Sure, absolutely. I think, as you've mentioned, we have clear targets to reach in terms of hemodynamics for our patients, but less clear are the agents to use to reach those goals. And as neurocritical care physicians, oftentimes we have to pull data on best choices from other paradigms. And really the sepsis literature is probably the most robust, in terms of being able to guide vasopressor choice. But importantly, TBI is definitely a different disease process from sepsis. And we know that, vasopressors based on, the known data have differential properties on cerebral hemodynamics as well as systemic hemodynamics. And what's best in one type of disease paradigm might not be best in other disease paradigms. So, as practicing intensivist taking care of TBI patients, I observe every day in practice and have looked at national data and, that there is a lot of variation in the choice of agent that we give to treat hypotension after TBI. And that's really what led to the motivation, basically observing the clinical variation, understanding that there might be differential effects of treatments, and uniquely, as we mentioned about TRACK TBI, having the opportunity to actually see if there's any potential impact on sort of 1-year neurologic outcomes, which we all care about in terms of the patients that we care for in the ICU.
Sure. And so in this retrospective cohort study, you included patients with moderate or severe TBI requiring vasopressor therapy within 48 hours of admission. And you described in the paper the primary aim to, again, describe the association of the initial vasopressor choice and 6-month outcome by Glasgow outcome scale extended. Why did you hypothesize that norepinephrine would potentially lead to improved clinical outcomes over other vasopressors?
Yeah, no, that's a great question. I think in other disease paradigms, and again, sepsis in particular, we have pretty strong guidelines as norepinephrine being a primary preferred choice for treatment of shock. And again, there aren't really strong studies of norepinephrine versus phenylephrine, but the preponderance of the literature would suggest that it's a superior agent to other vasopressor therapies. Its actions involve both a alpha and beta agonist activities. So while phenylephrine has alpha only activity and can increase the blood pressure, it might actually decrease cardiac output, versus norepinephrine would potentially increase both blood pressure and cardiac output. And the thought being that would augment cerebral hemodynamic and cerebral perfusion better than phenylephrine. And that combined with some science, some studies in cerebral autoregulation and mixed translational studies and basic science studies led us to the thought that the hypothesis that norepinephrine would be superior.
Thanks for explaining that rationale. It makes a lot of sense. I think a lot of us do use it as our agent of choice, given that it, again, helps us in a lot of other clinical scenarios in the ICU. And so why not TBI? And so before we discuss your findings, can you briefly summarize your methodology for your patient selection and data analysis? I was particularly curious to hear more about the methods used to account for bias. You mentioned a boosted logistic regression algorithm. And why was this important in the data plan for this study?
Yeah, no, that's a great question. I think one of the keys of any observational study in the space of critical care, we have to draw conclusions carefully and very carefully design studies because of this issue of confounding by indication. And many of the treatments that we give in critical care are simply because patients are sicker, and oftentimes we see worse outcomes in those patients, not really because of the treatment itself, but because of the indication for treatment. So that is clearly an issue in this study because norepinephrine is it's thought to be a little bit more of a more potent vasoconstrictor than phenylephrine. And, if we had to poll clinicians, we probably give norepinephrine to sicker patients. And, we wanted to try to use every tool available in our toolkit to try to limit the bias that creates. So one type of causal inference technique that we use to try to handle this is the use of propensity weighting. By using, a boosted regression model to create propensity scores for treatment, we did the best we could in an observational design to try to account for this confounding by indication by creating propensity scores for treatment. And using a propensity weighted analysis, we had one additional kind of causal inference tool in our toolkit to help try to account for some of the biases of the non-random treatment selection. To be completely to be fully clear, that is still, even using the most sophisticated causal inference techniques, there's still at risk for some residual confounding and bias in any of these analyses. It still does not replace a randomized control trial.
Of course. And in developing this cohort out of the TRACK TBI database, were there any other issues that came about in that patient selection and trying to identify the best cohort for this study?
Yeah, I think for our purposes, as best as we could, and again, under the limitations of not being able to do a full chart review for each patient, but being able to have the data set that was collected within the TRACK TBI cohort, we tried to create a population of patients where they were treated for hypotension early within their disease course. I think for all of us that take care of patients with brain injury, we would surmise that a lot of the secondary insults that occur early after injury are at a time when the brain could potentially be most vulnerable to a secondary brain injury. And also, we wanted to try to create a period of time where we are really focused on cerebral perfusion and shock as a result of either brain injury or the trauma itself, rather than a time period where patients could develop shock from other etiologies. And so, the 48-hour time period is a window oftentimes where we think of, trauma-induced shock, brain injury-induced shock. Choosing time periods, say, within that first week or even, the first couple of weeks of hospitalization after that 48-hour period could be due to all of the other things that we take care of, including sort of sepsis from, say, ventilator-associated pneumonia, PEs, or other etiologies for shock. So try to restrict as much as possible in this attempt to create as homogeneous of a population as we could. And just another restriction being sort of another sort of epidemiologic method in our toolkit to try to limit bias.
Sure. And again, makes a lot of sense. And that's what I appreciate about this paper. It's very practical, something that we really address every day in our practice in our ICU when we care for TBI patients. And so to transition to your results, can you describe your primary findings in regards to this association of vasopressor selection and outcomes?
Sure, absolutely. So, for our primary outcome of GOS at 6 months, we did not find a statistically significant difference in outcomes in norepinephrine compared to phenylephrine when in our fully adjusted propensity weighted model. And that was in contrast to our hypothesis, where we would have thought that, as we discussed earlier, the additional beta agonist effect, the cardiac output increasing effect, and potentially some of the cerebral hemodynamic effects of norepinephrine. Again, we had thought that potentially hypothesized that would have led to a better outcome, but we did not observe that in our study. Reassuringly, we didn't see a worse outcome with phenylephrine either. Basically, we saw no difference.
Sure. And again, I think it's still, great that we talk about these papers despite there not being this statistically significant finding. Again, it's still a very important question. It can lead into us gaining a better understanding. And so do you think that these results, sometimes we have to ask when we don't find maybe perhaps a way to hypothesize, do you think there was an impact on powering of the study, or the fact that it was retrospective? Does that give us any clues to how to address this question going forward?
Absolutely. I think it's opened up a couple of different thought processes for us that unfortunately the smaller size of this study would not allow further exploration. But I think one of the clear next steps in a larger sample would be potentially subgroup analyses, being able to see if there was a heterogeneity of treatment effects and in terms of potential patient populations having differential responses to vasopressor choice. I think that, from our own clinical practice, I think that makes sense. And it's hard to put all vasopressor therapy in a bucket. I think there's a certain amount of personalization of care that we need to think about in terms of hemodynamics. And I'll give you a couple of examples in which, each one could have, different impacts. Certainly, the patient with shock after TBI who, say, has developed a neurogenic stunned myocardium, for example, as, an etiology of the shock, then, in that case, norepinephrine may be a better choice, or an agent with some inotropic activity, versus a patient, for example, that, doesn't have that and potentially has a high degree of autonomic dysfunction, for example, and maybe the reflex bradycardia from phenylephrine may help, be able to help with that. So, I think that this speaks to, two items. One, being able to look at even potentially in the future a larger population to look for subgroup effects, and two, for us in critical care taking care of these patients, we may want to consider a decision on a vasopressor, a more nuanced decision. For example, maybe getting an echo, or being able to, understand what the status of the heart is before we order a vasopressor therapy.
And I did notice there were patients included that had intracranial monitors. And again, we're talking about small numbers here, but within this group of patients where we did have ICP data or even brain tissue oxygenation potentially, was there enough to explore that question of whether we were seeing those hemodynamic changes in the brain that were affected by the pressor choice?
No, that is a really, really good question. Our observations in those to really draw firm conclusions in terms of those subgroups in the sample size afforded by this study probably, won't be able to result in robust statistical differences. But that being said, responses to treatment are an important part of vasopressor therapy, and addition of vasopressors are also part of this. So, for example, in almost half of our patients after about the first day, so it's into day 2, many patients had a second vasopressor added for hemodynamic support. Both blood pressure responses and ICP trajectory and those second vasopressors. For this study, we considered those events that happen, say, like hours to a days after the therapy as sort of mediators. So we didn't particularly adjust for those in the analysis. We just considered them to be on the causal pathway between the exposure and outcome. But I think with larger cohorts and, for example, potentially being able to take advantage of multi-center like EHR data or, larger TBI collaborations that have higher sample sizes, we could certainly measure mediating effects and being able to understand sort of mediation and how sort of vasopressors affect outcome and sort of that full causal pathway. This sample just wouldn't allow such an analysis.
And was there any other signal in the data in regards to fluid administration, again, the concurrence of superimposed cardiac trauma, such as lung cardiac trauma, or any other signal that was either different between the groups that would have allowed it to be difficult to compare the pressor effect, or anything else that you found in looking at because you gathered a lot of characteristics about the patients, despite the limited numbers, there was still a ton of data to go through there. And in looking through the groups was, again, any other signal that would have maybe affected the ability to compare these groups?
Yeah, I mean, I think out of all of those injury severity, so in being able to get, a total injury severity score between both groups, the admission at GCS looked pretty similar, but the injury severity was a little bit higher, or the injury severity score is a little bit higher in the norepinephrine group, and this comes to that issue of confounding by indication. Potentially sicker patients were treated with norepinephrine, and what we did with these differences for this is we included those scores in our propensity model in order to be able to try to balance out on those key differences between the group. The one piece that I think is challenging in this study, but I wish we had, and potentially something to look at in a future study, is potentially being able to ascertain echo data and be able to understand what the ejection fraction and the state of the systolic and diastolic function of each patient's heart was, which was not an item that was included in this data set.
Sure, and given that it was retrospective, perhaps that did lead to the vasopressor choice at hand in clinical practice, since this was, again, just observational, looking at what people did and what happened. Maybe, again, the providers at that time had that data. We don't have it now. So perhaps that did lead to a slide bias that, again, would just be too difficult to account for. But again, I think gives us a great sense of, if you were to design this as a prospective study, what are the things that we would want to know in real time? And so I think it's still very valuable in that sense to have this as a great starting point for that investigation.
No, I agree. And I think having those variables and equally distributing them between groups sort of in a randomized fashion is, to me, one of the clear next steps of this work. With the group balances, one of the hopes using the propensity weight and care and collecting the other data is that we hope that we'll be able to, also at least balance out some of the unmeasured variables. So for example, by looking at the chest injury severity score, hopefully, that helps balance out cardiac injury. By being able to adjust for comorbidities, hopefully that would help balance out at least patients with pre-existing heart failure. But absolutely, there's always the risk for some unmeasured confounding.
Sure. And we've focused a lot of the conversation today on norepinephrine and phenylephrine, since those were by far the most commonly used vasopressors in this study. Did you find any signal maybe in this cohort or some of your other work that would make you think about some of these other vasopressor choices? And is there any role for them in the management of TBI patients?
Yeah, that's I think that the two questions that we've had in this in terms of vasopressor choice is one, the role of another vasopressor. I think from some of the sepsis literature, suggesting agents like, dopamine and dobutamine may have issues with arrhythmias and perhaps, not as great as outcomes as norepinephrine would potentially exclude those drugs. So from a first-line vasopressor strategy, given the equipoise that we're seeing, in this study and some of our other studies as well, here it was almost 50-50 in terms of who got phenylephrine and norepinephrine. I think being able to design a trial with equipoise that clinicians would buy into, I think using one of those two agents would probably be the best as a first-line agent. But as a second-line agent, we've, in this data and in other studies, we've noticed that in the phenylephrine group, sometimes norepinephrine was added. To the norepinephrine group, sometimes phenylephrine was added. I would really be curious of, rather than using those two drugs as a second-line strategy, to similar to potentially what we do in sepsis, is to consider the addition of vasopressin and how that might play into the cerebral hemodynamics and outcomes of these patients. So there definitely are unanswered questions in terms of vasopressor choice and other vasopressors. But from a randomization perspective for a prospective study, I think given how much variation there is, or sort of 50-50 in these two drugs, I think it would be most straightforward given current clinical practice to randomize on phenylephrine versus norepinephrine.
Sure. Were there any other takeaways from this project or in just your day-to-day management of these patients that you wanted to share with our audience?
Sure. I think that for me and my entire group, I think we found this data pretty reassuring, actually, in terms of there are situations where patients get phenylephrine versus norepinephrine. Classic example is a patient that, is coming up from the ER without a central line and, started a peripheral dose of phenylephrine, because that's oftentimes a bit more acceptable in a lot of health systems as compared to norepinephrine. And I think that, in those types of situations, I think, based on the data, I think we can be at least reassured that even if we, wouldn't have gotten our preferred agent, both appear safe at the population level. But that being said, I think that it also speaks that, at this point, as we make these decisions, we really may want to consider, rather than having just a standard way that we treat all of our patients, like every patient gets norepinephrine or every patient with shock gets phenylephrine. We're at the stage right now in TBI management where it has to be a little bit more nuanced and personalized. And I would consider, potentially recommend to clinicians that we, if there's available data in terms of echo, volume status, perhaps autonomic function, and pre-existing cardiac disease, to sort of put all of that information in your mind when making a decision on vasopressor choice, rather than just a one-size-fits-all treatment for patients right now, based on the data that we have.
Great. Well, thank you so much for sharing your findings and your thoughts in management of hypotension in TBI patients. You could find his paper in the February 22 issue of Neurocritical Care. Thank you for listening to the Neurocritical Care Society podcast.
Thanks for listening to the NCS podcast. The NCS podcast is produced by the Neurocritical Care Society, whose mission is to promote quality patient care, professional collaboration, research, training, education, and advocacy in neurocritical care. Our production staff includes Tariq El-Maghribi, Andrew Barishmet, Leonid Groisman, Atul Kalanuria, Lauren Kaufman, Cassie Cronfield, Holly Ledyard, Lindsay Marchetti, Alexander Reynolds, Lucia Rivera-Lara, John Rosenberg, Jason Siegel, Zachary Threkold, Teddy Yoon, and Chris Zaman. Our administrative staff and senior producer is Bonnie Rousseau. Music by Mohan Kadapali from the University of Miami Division of Neurocritical Care. If you like our show and want to learn more about us, check us out on Twitter, Facebook, or LinkedIn. The NCS podcast is available on NCS On Demand, iTunes, and wherever you get your podcasts. I'm Fawaz Al-Mufti, and thanks for listening.